by the World Health Organization and the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine. During the next hour, we will share summaries of 3 new publications related to cataract surgery that have been published today. First, an update on the global and regional data on effective cataract surgical coverage and its projections to 2030, published in Lancet Global Health. Second, published in Lancet Healthy Longevity, a deeper dive into cataract in Kenya, presenting a dynamic model that estimates the number of people that will die before receiving cataract surgery. And third, a summary of the new World Health Organization recommendations on quality of care in cataract surgery management, published by WHO today. In the second half, we will have a panel discussion about these topics with an opportunity for you to post your questions or comments in the Q&A function in the Zoom. My name is Matthew Burton, and I'm joined by 2 colleagues from the International Centre for Eye Health, Andrew Bastawrous and Jacqui Ramke, Stuart Keel, the technical lead for eye care at the World Health Organization, Monicah Bitok, the head of eye health services at the Ministry of Health in Kenya, and Amanda Huang, the chief of programs and partnerships at the Fred Hollows Foundation. Over to you, Stuart.
Thank you, Matthew. Sorry, it took me just a second to work out how to join. So thank you, Matthew. Great to be with you on behalf of WHO Vision and Eye Care Program in Geneva at headquarters. Welcome to everybody to this webinar. Thank you to the International Centre for Eye Health for their collaboration on the organisation, but also for leading the generation of the data that will be presented today. So it's a very important day, and it's an important day, of course, because cataract is the leading cause of blindness globally and a very important public health problem. And the new data that will be presented today is quite important for WHO because it tracks progress at the midpoint of the 2030 WHO target that Matthew will talk about very shortly, shed some light on some challenges moving forward, but also gives light to the progress that has been made as well. So WHO is also very pleased today to launch a new practical document for country stakeholders focused on minimum standards for improving quality of cataract surgery, and we'll be introducing that very shortly. So thank you again for joining. Back over to you, Matthew.
Thanks, Stuart. So first, an overview of the 2030 update on effective cataract surgical coverage. Cataract remains the leading cause of blindness globally. For the year 2020, it was estimated that 17 million people were blind from cataract worldwide. That's 39% of the total for blindness. Cataract is also the second leading cause of moderate and severe vision impairment globally, affecting a further 83 million people. Recognizing this enormous public health challenge and unmet need for cataract surgery, in May 21, the World Health Assembly endorsed 2 key indicators for eye care: effective refractive error coverage and effective cataract surgical coverage, ECSC. A set of targets for ECSC of 30 percentage point increase by the year 2030 from the 2020 baseline, while paying careful attention to equitable service delivery. In 2020, WHO convened a working group to develop definitions and methodologies for new indicators. You can read about these in this report published in 21. ECSC is an effective coverage indicator, which is WHO's preferred approach. It's a population-level indicator that is derived from surveys. In summary, it's defined as the people in a population with a good visual acuity outcome following cataract surgery, as a proportion of those who currently have unoperated cataract, plus those who have previously had cataract surgery. In 2021, WHO also updated the definition of a good surgical outcome from 618 to 612. As mentioned, ECSC is a population-based estimate from survey data. The primary source of data on ECSC is currently the Rapid Assessment of Avoidable Blindness Survey methodology. RAB7 is the latest generation of RAB delivered digitally. It enables faster, more accurate collection and analysis of secure, high-quality eye health data relevant to current eye health priorities, It includes an optional module for the collection of additional data around diabetic retinopathy. RAB7 has been developed through a collaboration between the International Centre for Eye Health and Peak Vision in consultation with a steering group made up of representatives from key stakeholders in the global eye health sector. A population-based sample of people is assessed for current cataract and prior surgery. There are 3 metrics that we typically then calculate in relation to cataract surgery: cataract surgical coverage, effective cataract surgical coverage, and the relative quality gap. So taking this hypothetical example of about 1,000 people, 80 people have untreated cataract, the red dots, and 40 have had cataract surgery, the blue faces. Firstly, to estimate the cataract surgical coverage, CSC, you divide the number of people who have previously had cataract surgery, irrespective of the outcome, by the number operated plus those with unoperated cataract. So in this example, the CSC, the cataract surgical coverage, is 33%. To estimate the effective cataract surgical coverage, you need to take into consideration the outcome of the surgery. Some operated people will have non-good outcomes, indicated in purple. You divide the number of people who've previously had cataract surgery who have had a good outcome by the number of those operated plus those with unoperated cataract. So in this example, the effective cataract surgical coverage is 23%, down from 33% for the cataract surgical coverage. The third metric is the relative quality gap. This is the difference between CSC and ECSC as a proportion of cataract surgical coverage. And again, in this example, the relative quality gap is 30%. The baseline effective cataract surgical coverage report, which included 55 countries, was published in 2022, and this fed into the WHO baseline report on the indicators. This updated report, published today, builds on that on an expanded list of primary data sources. It includes 233 surveys conducted in 68 countries to provide empirical estimates for ECSC at the 6/18 level, estimates of the relative quality gap and an analysis of its causes, and finally modeled temporal trends from the year 2000 to 2030. I'd like to draw your attention to not only the paper, but the appendix, which has a lot of additional detailed material on the methods, surveys used, and the results. This figure plots the cataract surgical coverage, CSC, with the blue markers towards the right, and the effective cataract surgical coverage, ECSC, with red markers towards the left, for each of the 68 countries. And the line between the 2 dots, the red and the blue dot, reflects the quality gap. There's a very wide range of values for all 3 metrics, with ECSC ranging from only 2% at the lowest and 78% at the highest. The regional median ECSC values at the 6/18 outcome threshold range between 15% in the Africa region and 45% in the Eastern Mediterranean region. More recent surveys have visual acuity reported to the 6/12 threshold. And when you calculate ECSC at 6/12, you see the anticipated slight drop in values for ECSC for all regions. We use data from 120 RABs that analyze visual acuity to 6/12 to calculate the overall and regional median percentage contributions of causes of non-good outcomes in people who've been operated. At the global level, refractive error and ocular mobility accounted for 26%. Intraoperative complications for a further 20%, and posterior capsular opacification for 11%. The median percentage point increase in ECSC at 6/12 might be achieved by addressing refractive error was around about 4% extra overall. 17 locations had ECSC values at 6/18 from surveys available from 2 time points several years apart. These are shown in this graph, and for 9 of these countries, the 95% confidence intervals don't overlap, suggesting a significant increase. The largest percentage point increase in ECSC at 618 was 27% for Qatar between 2009 and 2023. With the exception of Mali and Senegal, there was limited evidence of increasing ECSC at 618 in the African region. We used 228 datasets to model regional and global estimates for ECSC at the 618 level for the period from 2000 to 2030. These figures show the trends for the WHO regions. In the current decade, from 2020 to 2030, the modelled increase in ECSC at 618 was 4% in the African region, 8% in the Americas, 6% in the Eastern Mediterranean region, almost 14% in Southeast Asia, and 18% in Western Pacific. There's currently insufficient data to model this for the European region alone. For the year 2025, at the global level, the model predicted ECSC at 618 to be 48.2%. Between 2000 and 2020, there was an estimated increase of 15.6% in the ECSC. And for the current decade, from 2020 to 2030, we estimated only an 8.4 percentage point increase globally. This is set against the overall target of 30 percentage points. Globally and regionally, ECSC is increasing much more slowly than the World Health Assembly target of 30 percentage points in the current decade. Action to increase cataract surgery is urgently needed. Overall, the relative quality gap remains large in all regions, and addressing post-operative refractor is realistic and would boost effective cataract surgical coverage. And it's important to report the reasons for non-good outcomes to inform and drive quality improvement. So thank you very much for listening. I'd particularly like to thank 4 colleagues at the International Centre for Eye Health who've led on the analysis: Ian, Yamna, David, and Jacqui. Particularly like to thank the wider effective cataract surgical quality coverage study group, which involves people from many, many countries contributing data. And finally, to thank the funders, the Indigo Trust, the Wellcome Trust, and the Fred Hollows Foundation, who supported this work. Thank you very much. Over to you now, Andrew.
Thank you. Thanks very much for that, Matthew. Thanks very much, Matthew. Great to hear that presentation. I'm going to share a further study which builds on the work just shared there. So this is looking at the prevalence of death in people with vision impairment from cataracts prior to accessing treatment, and it's a case study from Kenya. I'd like to acknowledge that this work was done by a group of co-authors who are shown here, so colleagues from the International Centre for Eye Health from WHO and from the Ministry of Health in Kenya. These numbers and the data are quite alarming in terms of progress, but what does it mean at a human level? And so I'm sure everyone on this webinar understands that cataract is something that we've made great success on in terms of innovation over the last few decades, so it being a very fast, effective operation. Yet the reality is we still see images like this, which is a photo I took 15 years ago whilst working in Kenya of this lady being brought to a clinic who had been blind for 10 years with cataract. And when she sat in the outreach clinic amongst other people, 23 that day, that we were going to take 10 minutes away to the hospital for treatment, these 2 ladies who'd both been blind for a decade didn't know that they were sat next to each other despite having been best friends for many years. And so the issues created by cataract obviously go way beyond just vision loss, but also a sense of connection to the community. And for both of them, all that was required was this 10-minute operation. So when we're thinking about this data in terms of the quality gap and the coverage, these are real people who are unable to access services. And so we wanted to ask a question, which was, given that data in terms of cataract surgical coverage and effective cataract surgical coverage, how many people are accessing services and what will happen in terms of proportion of those who don't? So to model that, we started with what we would call the cataract can. So that's the proportion of people on the backlog. So those are people like those two ladies who are waiting for surgery, and then those who've been operated as a proportion of the population, as Matthew showed through surveys such as the rapid assessment of avoidable blindness. Now, when you add in other data, including the cataract surgical rate, which is the number of people operated per million per year, that's the transition of people from the backlog, so waiting for surgery, to operated. Another key element is how many people are being added to the backlog. So how many new people are developing cataract vision impairment per year. And you start to see quite quickly how this model starts to build. So for example, if the new cases, so the incidence, is greater than the number of surgeries being done, what we see is the backlog growing over time. If it's the other way around, if the cataract surgical rate is greater than the new cases, then you start to erode that backlog. And so one of the ways like to conceptualize this is if you imagine you've got this container of people, so there's only really two ways out. So if you're on the backlog, you either leave the backlog by having surgery or you die untreated. So one of the ways to conceptualize this is as a bathtub. So incidence is the rate at which water is filling the bathtub. So those are your new cases. The backlog is how much water is contained within the bathtub at any one point in time. The cataract surgical rate is the rate at which water is leaving the tub. So that's the drainage. And if the drainage is greater than the water coming in, then that level will drop. So the backlog will drop. Equally, inversely, if the rate of water coming in is greater than it is being drained, eventually it starts to overflow. And it's the overflowing here, which is the proportion of people in the cataract backlog who are dying before they access treatment. And so this is the question we wanted to answer is how much is that overflow? How many people are dying before accessing treatment? And so with colleagues, we took Kenya as a case study. And first to put in context, Kenya as a country in the sub-Saharan African region is performing better than the majority of other countries with relation to effective cataract surgical coverage. So this is from the ECSC paper. And you can see in the African region, Kenya is actually one of the highest performing countries overall. So just to take that in the context of the data we're about to share. Recently, in 2022 to 23, 10 RAB surveys covering 14 counties of Kenya were conducted by the Ministry of Health in partnership with CBM. And that data showed that for the whole country, the current number of people on that backlog today stands at around 360,000 people who are vision impaired from cataract. So that means they have a vision impairment in either eye, and at the moment they're in the better seeing eye. So that person is vision impaired. We also have data from the ministry that around 40,000 cataract surgeries are being conducted per year. And that translates from a cataract surgical rate of around 700 per million per year. So to calculate the incidence, the number of new people entering that backlog requires a longitudinal study. So an assessment of people over time to see how many people develop new vision loss from cataract. And so many years ago, as part of my PhD in the Nakuru region of Kenya, there was a baseline study conducted by Chiku Matenge in 2007 and 8. And then 6 years later, I followed up those 5,000 people over 6 years to see how many had developed vision impairment from cataract and other causes over that time. And so the data from that paper gives us a fairly accurate model of how many new people are developing cataract vision impairment per year. So when we plug that into the model, we now see not only how many are on the backlog and how many operations are happening per year, but how many new cases are being added per year. And so straight away, you can see 120,000 versus 40,000 is an imbalance. So the inflow here is greater than the outflow, which is a problem. So our question is, given that dynamic, how many people are leaving the backlog, not through surgery, but from dying before accessing surgery. And so to answer that question, we built a model which has various assumptions in, all of which are included in the paper that's been published today. And what it showed is, of that 360,000 people on the backlog in 2025, over the next 5 years, the new cases, which will be around 600,000 cases, will come into the backlog. And of that original 360,000, 236,000 will have died before accessing treatment, and only 67,000 will have been treated. If we project that all the way out to 2040, which is the time by which everyone on that original 2025 backlog will have either been treated or accessed surgery, we can see that number grows to 280,000. So that is 77% of the original 360,000 people. So more or less 3 in every 4 people who are vision impaired from cataract in 2025 will die before getting treatment unless something fundamentally changes. And what that means is, for individuals like these ladies who did go on the next day to access cataract surgery, the reality is that the types of scenes that we're, as a sector, keen to celebrate moments like this where they get the surgery. The reality is that will only happen for 1 in every 4 people who are on the backlog today. And so we intentionally built this model to understand what this means in terms of people not accessing services, but in a way to hopefully have a more compelling and emotive message when we're going to policymakers, when we're going to funders, when we're going to other stakeholders that we need in our sector to help change this reality. Thank you very much for listening.
Thank you very much, Andrew. Congratulations again, Andrew and Matthew, for this important data, and to all collaborators on the data. So, as mentioned before, my name's Stuart Keel. Today, I'll be very briefly, before we move to the panel, very briefly introducing the new WHO document that is also being launched today, which is a summary of recommendations for quality of care in cataract surgery management. A bit of a mouthful. This is intended really to be a practical document for governments, NGOs, other stakeholders who are involved in implementing cataract surgery in countries. So just going back to put this into context, Matthew spoke earlier about the global target and how we're tracking towards achieving this 30 percentage point increase in effective cataract surgery coverage. But what's very important to highlight, and what has come through very strongly in the presentation, is as countries set about strengthening cataract surgery services and meeting this target, both components of the indicator are very important, and that is access, but also quality, and quality really needs strong consideration. And the importance of quality was highlighted in the Lancet Global Health publication, which found that the relative quality gap between coverage and effective coverage was around 36.7%. So this means approximately 1/3 of people who underwent cataract surgery currently do not have a good visual acuity outcome. So of course, we also saw a breakdown of what the causes of the poor outcome were, many of them being addressable. Things like access to eyeglasses, access to laser treatment, access to post-operative laser surgery as well. So what this does highlight is that in settings where the delivery of quality cataract surgery remains a challenge, there is a significant opportunity to improve effective cataract surgery coverage, often through measures that don't involve a huge amount of additional investment. So the measure of effective cataract surgery coverage captures a very important element of quality, but it's important to emphasize that it's not the only element of quality that we need to consider when planning for cataract surgery management. There's several other very important components that need to be considered, including safety, people-centeredness, timeliness, equity, integration, and also efficiency. And with this in mind, and in order to assist countries and stakeholders who may require guidance in this area, WHO, through consultation with a large group of international experts, developed this document called the Summary of Recommendations for Quality of Care in Cataract Surgery Management. So this is now available, and I believe the link is in the chat. So what is it? It is an evidence-based and expert-agreed recommendations for improving the quality of cataract surgery that are applicable to most settings, feasible in most settings. And it covers the three main elements of cataract surgery, which is preoperative care, intraoperative care, and postoperative care. And what does it include? It includes recommendations for the quality of care across 7 key components of preoperative care. They're included on the screen here. They include things like recommendations, minimum quality standards for preoperative assessment, for wait time for surgery, recommendations on the use of optical biometry, IOL availability, those types of key factors. It also includes recommendations for 7 key components of intraoperative care, things like guidance on surgical technique, infection control, and intraoperative complications. And it includes 4 key components of postoperative care, such as recommendations on minimum standards for postoperative visits, for outcomes, as Matthew mentioned before, and also complications and related rates with these complications. Who is the target audience for this document? The primary target audience is policymakers and cataract surgery service planners, also managers of eye care programs, but other potential end users include eye care service providers to put into action the recommendations at a facility level, health professionals to verify and align the care provided with standardized evidence-based clinical care, and donors and development agencies when supporting cataract services provision in low and intermediate resource settings. So I encourage you all to go to the webpage, download the document where you can see it in its full scope. Just a very brief introduction today, but before I leave, I would like to acknowledge the huge number of experts listed on the screen here from all regions involved in supporting WHO in developing this document. Also wanted to mention a thank you to the Dana Centre of Preventative Ophthalmologists for supporting the pre-review of existing guidelines for cataract surgery. And last but certainly not least, I wanted to thank the Fred Hollows Foundation for their generous financial support provided towards developing this document. And with that, I will stop and pass back over to you, Matthew. Thank you.
Thank you, Stuart. We're just waiting for the other speakers to join us in here. Hopefully this will happen in a moment. Just apologise for some of the technical challenges we've been facing. Hopefully it's that's a bit smoother now. So we've got just under half an hour together now to just discuss some of the things that we've been hearing about. I've got a number of questions, and then I noticed that we've got a few questions already coming in the Q&A on the Zoom. So if you've got questions, please do put them in the Q&A, and we'll try to either speak to them during the course of this meeting or in written responses afterwards. Great. So first question goes to Monicah. Given the persistent backlog in many countries that we've just been hearing about, which health system innovations do you think are proving most effective at scaling up cataract surgical services?
Yeah, thank you, Martin, and greetings, everyone. I think when it comes to scaling up cataract surgical services, we need to look at this from the demand side and also from the supply side. And from the demand side, I'd like to start by talking about what we can do at the community level. We need to address the barriers that are often faced at the community level when it comes to accessing cataract surgical services. And some of the key barriers include financial barriers or cost barriers. So we need to find strategies to address the cost issue so that people are able to access services and are not turned away because they cannot afford the services. The other thing is physical, ensuring that there is accessibility physically. And this is taking into consideration the different geographical vastness in different countries and even in different counties, even within a country like Kenya. that you'll find that some counties are quite vast and the geographical access becomes quite difficult. So how do we then come up with ways to ensure that we are taking the services closer to the people and not necessarily waiting for them to come to the base facilities? So perhaps strategies around mobile eye clinics, outreaches, just taking the services closer to the people. And then the other barriers that you see at the community, again, is a lot of misinformation and misconceptions. So we really need to strengthen health promotion so that we address some of these myths and misconceptions, and so that people can come forward to seek these services. And some of the strategies we can use is sharing success stories, or even using those who've had successful cataract surgeries to be our champions and to promote positive attitude towards uptake of cataract surgical services at the community level. We also need to target the opinion leaders at the community, because they are the ones who enable us to enter the communities and to talk to this to our community members so that they can come forward for cataract surgical services. So bottom line, we need to work with the communities, and when communities trust our services, then they're able to come forward and demand these services, and that automatically increases or naturally increases the demand. The other area that we need to look at is when at the health system side, and these we need to ensure there's a continuum of care, so that you're not just offering services at the secondary and the tertiary level facilities, but you're also having primary eye care integrated into primary health care. Because most of the time, the first contact patients come across usually are primary healthcare workers or the frontline healthcare workers. And it's really important that they are capacity built with basic skills or basic knowledge on eye health, because they're the ones who help us in identifying these patients and ensuring that they are referred appropriately. And the primary healthcare, again, when you integrate primary eye care, it becomes like a triage and a referral mechanism for eye care services. Then at the secondary level, we also need to ensure that our patients are getting a positive experience. When they come, services are efficient and they have a good experience. We have reduced waiting time, proper patient flow, and all that. Then when they go back to the community, they help us in advocating. They become our advocates, basically, and they ensure that the demand also goes up. So when the clients are satisfied based on the services that we are offering, and they get positive outcomes, and they directly drive the demand at the community level. Then at the policy level.
Yeah, I was wanting to ask you a bit about policy. What policy levers have you found to be really useful in the Kenyan context?
Yeah, so policy is really key in driving or in scaling up cataract surgical services. And some of the policy issues or policy levers that you can look at in Kenya, for example, is use of that's on health financing. And we have what we call the social health insurance that has a package for eye health and for cataract surgeries. So ensuring that as many people as possible are enrolled into these insurance services, so that they can be able to access services at an affordable cost. Because when we leave them to depend on out-of-pocket expenditures, then they really struggle to access these services. So insurance is really important. Health insurance at the national level is really important, but also using mechanisms like ensuring that eye health is integrated into primary health care, into community health is really, really key. Because, as I said, the primary healthcare level is where most of our patients enter the health system, and that level is capacity built, then they're able to identify and refer patients appropriately. Then also ensuring that we have an enabling environment by having policies that ensure there's a strengthened supply chain system, there's a strengthened human resource system that ensures that we have equitable distribution, and just ensuring that you're addressing the health system building blocks so that we address eye health comprehensively. And some of these have to be done at policy level. Yeah, thank you.
Great, Monicah, thank you so much for sharing those insights. Can I turn to Amanda now, please? And it'd be lovely to hear from you what you're finding through your work, both personally and Fred Hollows Foundation, are the primary causes of differences in quality in cataract surgery between countries.
Thanks, Matthew. I hope you can hear me clearly.
All good.
Thank you. Thanks, everyone. Well, when we look across countries where the Fred Hollows Foundations, we have programming supporting cataract services, I think the difference in cataract quality are really about surgical technique alone. And in most settings, I think the real difference really sits at system level. First of all, for example, training pathway and ongoing mentorship varies enormously. In some countries, surgeons have structured supervision, peer review, continuous learnings built into their practice. In others, once formal training ends, there are very limited mechanisms to support continuous learning and also quality improvement. And secondly, I'd say data availability and utilization also varies a lot. Many countries do not routinely collect or review visual outcomes or patient experience status. Without data, outcome data is very difficult to understand where quality is leaking or how to focus and improve the quality. And we see countries where we do have systems like cataract surgical outcome monitoring programs. The quality improvement seems faster and more sustainable. And I think the third area probably is health system and facility reliability, which really matters just as much as individual skills. And this, for example, may include consistent access to functioning equipment, maintenance systems, standard operating procedures, a series of workflows. In some settings, availability of supply chain and equipment downtime can directly affect surgical outcome, consistency, and also patient safety. And finally, I would say governance and accountability really play a big role. Countries that embedded quality expectation into national policies, accreditation systems, and reporting frameworks tend to see much more consistency performance across facilities. Where quality is treated as optional rather than essential, it really varies. From our experience at the Flat Earth Foundation, for example, including some of the recent continuous quality improvement work in China and across Asia and African regions, countries that perform best are those that treat cataract quality as a health system responsibility, not just as individual clinician issues. So in short, I would say quality difference really reflect a policy choice and a system designs, not just clinical capacity.
Thanks, Amanda. And what actions have you seen or found have really helped to promote increasing quality, both of delivery and outcomes?
Thank you, Matthew. What we've learned is that quality improves when actions are structured, data-driven, and also embedded into routine health systems. One of the most effective actions has been adopting clear shared quality standards, such as what we are discussing today, the new WHO cataract quality guidance. These standards helps align expectation across government ministries, hospitals, facilities, clinicians, and also patients. And importantly, this can shift the conversation from a single focus on volumes, the number of services provided, to effective coverage. And secondly, I think routine outcome monitoring is transformative across our global continuous quality improvement work, including, for example, pilots in Bangladesh, Kenya, Ethiopia, and more recently scaled programs. Introducing simple outcome monitoring system has enabled our teams and partners to identify problems earlier and test the solutions quickly. For example, in China, our CQI work has focused on embedding outcome monitoring and continuous quality improvement into existing national cataract capacity building systems. So rather treating this as a parallel process, we work with partner and ministry to including tools such as PDSA cycles and outcome review into hospital practice and also training programs. And this approach has helped normalize quality improvement as part of routine care, not standalone project. And thirdly, for example, in our Nepal program, mentor-mentee peer learning also matters enormously, where between hospital, surgical team, or province, these mentor-mentee programs allow a practical problem solution-based peer support mechanism. And we've seen this work particularly well when combined with regular data review and a facilitated learning process. And finally, quality improves when we also put the lens of people-centered care, better preoperative counseling, realistic expectation setting, and also improve the follow-up, not only improve outcome, but also increase patient trust and also compliance. And across all these actions, the key lessons learned is consistency. When quality standard, data, training, governance, leadership reinforce each other, as encouraged in the WHO guideline, improvement becomes sustainable. So overall, addressing cataract blindness and vision impairment remain as one of the highest priority for the Fred Hutch Foundation. And we continue to work with WHO and partners across the globe to promote these tools and help strengthen health system.
Great. Amanda, thank you so much. Really helpful insights into the value and importance of data driving quality improvement and then approaches to systematically working on that. I'm going to turn to Jacqui now, and I'd like to ask you about how the data we've been talking about today and similar data can be used to better understand inequality in the provision of cataract services, please.
Yep, thanks, Matthew, and congratulations to everyone who's presented today. I guess I wanted to highlight a point that we made in the paper, which is that the lack of a significant gender disparity that we found, was only a 2% difference between men and women, ECSC in the paper. The fact that we found that at a global level doesn't mean that we've solved gender inequity, and just highlighting that it's encouraging that we're moving in the right direction, but that the estimates are aggregated and modelled. So underneath that sort of global estimate, there's still be many settings where gender disparities persist. So I guess I just wanted to encourage everyone to continue to use local data to sort of drive gender responsive programs. And then the second, sort of along similar lines, I'm sort of wanting to encourage us to think about expanding the social axes that we use to monitor inequality. So, and this will be really different in different settings. And just thinking about perhaps some of the work that's in this new WHO document, but certainly in the ICARE indicator menu, we have some measures in there that we can use to monitor whether or not we're moving in the right direction. Such as access and quality in terms of the key components of ECSC. And I thought sort of preoperative visual acuity is a really nice example of a measure that we can use as a proxy measure for access. And so here in Aotearoa, New Zealand, where I live, thinking about our ethnicity is a crucial social axis that we have to use to monitor cataract services, because our Indigenous peoples, Māori, we know that they access services with much worse preoperative visual acuity than other New Zealanders. And so it's a key sort of example here that we can be using these service-based indicators to know whether or not we're moving in the right direction towards effective cataract surgical coverage. So for us, knowing that we need more accessible services for Māori, even though we don't have survey data here, but we can use that to know if we improve access for Māori, we'll be moving towards improving ECSC for the country. So,
Jacqui, just a short follow-on question. I know in the past you've done quite a lot of work on looking at multiple, as you mentioned, multiple axes of differences between people and how those characteristics can interact with each other, leading to some groups being really disproportionately left behind. Can you just speak to that a little bit and the value?
Sure.
Of that?
Absolutely. And yeah, so it's sort of this cumulative disadvantage, or the cumulative barriers to services, the more axes along which different population groups may experience barriers. And so a key example would be for gender. So not all women are the same. So there are women with plenty of resources who are able to access services. And so it's thinking about within women and thinking about the populations that we're serving, what would be the axes that might combine. And so obviously rurality is a big one. So if it's rural women or rural women without good social support, so maybe women who are not married or women along socioeconomic status and things. So it's sort of not just thinking about men and women as a group and women, the gender disparity is not now gone away, because underneath that will be these other things that we need to think about.
Great, thank you. Thank you very much. Stuart, can I turn to you now? question really here is what are the caveats? What caveats are there in using CSR, cataract surgical rate, and ECSE, both for progress and reporting? Would you say?
Yep. Yeah, thank you, Matthew. I think it's a very good question, and I think it's been highlighted a bit throughout some of the responses. But so effective cataract surgery coverage, in particular, if we stick with that for a moment, of course, is an important indicator to periodically track the impact of the work that's been done in the country at a country level in terms of access and also quality. It sort of gives a one point in time snapshot of the quality and access to service. However, the key point is, and it has been mentioned by Jacqui, a much more comprehensive set of indicators are needed to inform evidence-based planning and decision-making around cataract surgery in countries. And WHO has dedicated some time and resources in this space. In 2023, we launched a standard set of routine health information system indicators in a DHIS2 module. Within that, it includes additional indicators such as waiting time, preoperative visual acuity, and surgical outcome. But we're building on that at the moment, and over the course of 2025 and 2026, we're developing a case-based reporting for eye care indicators, but it's very heavy in cataract surgery-related indicators. It includes even additional indicators such as dropout rates, complication rates, those types of things as well. So we're looking forward. We are going to prioritise this moving forward, and we're in the process of identifying a few countries now to pilot this work so that we can move it forward and make it more widely available.
Great, thank you. And do we need additional indicators to better capture coverage, do you think, quality and equity? And do you think we've got the toolkit we need?
Yeah, I think we're heading towards the appropriate toolkit, but I do really need to underline the fact that the work needed around supporting countries to strengthen their health information systems is critical. It's not easy. It needs some alignment in terms of HIMS processes in countries, convening of experts in countries. So that's really the key point I'd make. So really, we need all stakeholders in countries to come around this and really come together to support strengthening of eye care data, including cataract surgery indicators within routine health information systems in countries. I think we're getting there with the level of indicators now.
Yeah, great, thank you. Andrew, can I turn to you and just ask you about incentives? What sort of incentives do you think need to change for the problem of cataract to be addressed sustainably?
Thanks, Matthew. I'll answer this in two parts. First, kind of building on Stuart's point and Jacqui's around different types of indicator. So obviously ECSC is a visual acuity based indicator, and I think anyone who's in clinical practice will know there are patients who have a poor preoperative vision and have a slight improvement, who it's transformative in terms of their life and function and quality of life. Equally, there are some who move across a threshold of visual acuity for whom it doesn't change their visual function. So I think it's partly acknowledging that a quality outcome has multiple dimensions, and I know that's covered in the new WHO guidance as well. So that starts to feed into what are the incentives. Our quality of service is a key thing. So we can think that how else do we measure that quality of service? There is a challenge, and a very real one, that I think we all need to be alive to, that if you are a eye care provider in a low income setting, you are often put in a position of having to choose between either doing well or doing good. So if you want to make a reasonable living and income from your work, you tend to need to work in the cities where people who can pay out of pocket with a decent margin exist. And so as an incentive to do surgery in the rural areas where the greatest need is, actually at the moment that there isn't a strong one. It's largely a moral one. And we're very fortunate to be in a sector where there's many people who are committed to that, but that's not enough. So I think the challenge ahead of us, and Monicah touched on it in terms of financial security and systems around this, is how do we ensure that if demand is generated from people in the lowest income settings, that also balances with reliable, regular income for the providers, so that they can move from doing outreach type activity as a externally funded program to a self-funded program, because there is not just a, if you like, mission incentive to do so, there's a financial one to do so. At that point, the system will start to pay for itself, and we'll move from a current problem of lack of patient financial access and lack of supplier financial security to grow, to how do we optimize the system for improvement and growth. Because the risk is we can have all of the processes and toolkits around improving services and monitoring, but if there is not an incentive at the level of the provider to stay in that job, to grow, to do more, we don't have the underlying support system for that to happen. So I think we really need a way to address that.
Thank you, Andrew. Really insightful observations there. Lots to think about. Jacqui, can I come back to you, please, and a bit of a question about data and what you think the biggest challenges, but also the opportunities for collecting high quality cataract service data, potentially.
Yeah, so I think a key opportunity is the potential for the increased value that countries might place on cataract service data now with the WHO target and the reporting needs. And we're sort of working on a really exciting project at the moment in China and Nepal in partnership with the foundation and the respective governments and NGS. And I think looking at, as we're sort of working towards, our question is there a way for us to work towards being able to update ECSC estimates using routinely collected data? And it's been really exciting to work with partners in the country and seeing the increased interest in cataract service data, which is collected at facilities, and the quality absolutely could be improved. But there's a lot of service-based data there that we can be knowing if we're moving towards driving up ECSC. So I think that I think Amanda and Stuart have already said it so well. It is an opportunity to, and sort of working together to improve health information systems, I think is a really critical way, but also working with governments to so that they can see the value of this in terms of their reporting obligations. I think it's a challenge and an opportunity.
Great, thank you, Jacqui. Just in the last few minutes, can I circle back to Stuart and then potentially Andrew to think about people, human resources, and what you think are some of the key challenges and opportunities, again, in relation to the eye health workforce?
Yeah, so I'll be extremely quick, Matthew. So no doubt, of course, a lack and maldistribution of workforce at all levels, from screening to diagnosis to actually surgeons as well, is one of the key bottlenecks to increasing access. So I think Monicah said it very well. I think the strengthening of the health workforce needs to happen at all levels, including the primary health care levels. I wanted to also flag that WHO has just released in December last year some new primary eye care training resources to support this exact thing. Of course, then, we need standardized training programs for surgeons as well to increase number and better the distribution. But it's also about addressing the inefficiencies some inefficiencies. Of course, at the moment, we see in many countries, ophthalmologists and surgeons are really tied up with non-surgical tasks quite often. So freeing their time up to do what they do best, to do surgery, is also something that can only happen if we strengthen the lower levels of the health system.
Great, thank you. Anything to add, Andrew?
Yeah, I mean, I think Stuart covered all the key points, and just on the maldistribution and inefficiencies, partly when we look at the data, it's often 20% of the surgeons are doing 80% of the surgeries. So when we talk about needing more surgeons, actually, I think the first problem to tackle is more surgeries. And if you have more surgeries, it's that incentive system. People want to work alongside other surgeons and surgical teams and have mentorship and community. Then it becomes an attractive profession. So it goes down to, you get the demand right through strong primary eye care, you get the quality right. All of these things need to come together in concert for this to work.
I think we are almost at the hour. It is easy for me to say thank you very much for those of you who've joined online. We really appreciate the time you've given us today. Thank you very much to the panel for the presentations and for the really lively and interesting conversation. I'm mindful that there are a lot of open questions in the Q&A, which we'll seek to respond to in writing. Unfortunately, there isn't time to take these now, but there are some really excellent points suggestions and questions there. So thank you very much.